Good morning everyone, thanks for coming along. So delivering effective patient-centred services is obviously a very important thing, central to integration. It's my pleasure to introduce Fiona Murphy to you this morning. Fiona is the Associate Director for National Information and Intelligence at ISD, and Fiona is going to share her experience regarding data and how we can use it to shape integrated services. So Fiona, over to you.
So we've been commissioned by the government to develop data to support the new health and social care partnerships and the integrated joint boards. So ISD has collected health data for the past 50 years or so, and what's unique in what we've been asked to do is to link that at a patient level to the different data sets that we collect for health, and also to link that to social care data. So yesterday, Jeff Huggins presented a little bit of data on what we have, which allows you to get right down to individual patients and understand what's happening to them, understand the services that are being provided, and give some of the integration boards, I suppose, some short-term ideas about what they could do to start redesigning services, and also help them plan for the longer term. So we're doing three things. One is about making sure that we have all the data. So just now we probably have data at individual level that covers about 70% of what the health and social care partnerships are responsible for. So the rest is aggregate, and about 70% is individual. So we want to fill up some of the gaps, particularly in community health activity. District nursing will come on stream this year, mental health nursing beyond that. And then our second thing is to provide a platform for people to be able to access to that linked health and social care data. So we have a platform that you can see at Scotland level, or you can come down to your partnership, or professionals can get right down to individual patients, so they can look at maybe a cohort with diabetes, or a cohort with dementia, or people who are delayed discharges and so on. And then the third element is about putting some help out there to help the partnerships. So we've a set of information specialists, 17 of them just now, and building up to 30 over the year, that will go out and work with the partnerships to help them to use the data, to understand it, start thinking about their planning. One of the difficulties, I guess, that people face is that there's so much information, and trying to navigate your way through what's there can be very tricky. So we've been asked to put some on-the-ground support, and we've called it our local intelligence support team, that'll go out and help the partnerships on that. So that's kind of an overview of what we're up to, but happy to take any questions or thoughts, or hear what people think they need around information. You're from a partnership?
I'm from a partnership, yeah. I'm actually from the social care side. And yes, absolutely, it's really interesting. I didn't realise that we could get information at the patient level already.
So the social care data is just coming in.
Right, okay.
So at the moment you can get hospital admissions, all the community prescribing, things. There's a tool called SPARA that helps to identify people at risk of admission to hospital.
Right, yeah.
You can get all of that individually, and partnerships are just returning the social care data, so that will include care at home, care homes, self-directed support, IRN, the indicator of relative need. But it's up to partnerships what they want to send in. So if you just want to send in about care at home, that's fine. If you want to send your entire data set, that's fine as well. It'll be up to this is what suits the local area.
So, and will there be a dedicated person for each part? When will that actually happen? Will we know a name of?
You will, so actually on the leaflet there's an email address to go and check, but I know they've been up talking to the 3 partnerships in Grampian already about what they could do. So yes, there'll be a named person per partnership, and I guess although that person will be there to help, it's also about them linking into what's nationally available to support people. So
I'm interested in the use of the data, because obviously there will be a huge amount of data, down to the individual level of the patient. So I'd be interested, and this is maybe a bit early, as to how that data can be used to improve the services that Mrs. McDonald gets, for example, at an individual level.
Okay, so I'll just repeat it for the sake of the mic. So it's about how data is used locally to help individual patients. So a couple of examples. I suppose one of them is a lot of resource across health and social care tends to be concentrated actually on very few individuals. So about 2% of the entire population account for about 50% of what's spent in health and social care, and across Scotland that's roughly about 100,000 people. So we can help identify who those 100,000 people are, and it's been surprising to some of the partnerships actually who they are, because you think you know the people who are high users, but often there's people that you're missing that are maybe getting a range of services, but those services aren't particularly joined up. So by identifying that actually this is a person who's been in and out of hospital 3 times in the past year, is getting help from social care and from community pharmacy and so on, you can add that up together and present it back. And some of the partnerships are looking at, well, who's the next 2%? Who are the next 100,000 people? And what can we do about redesigning the pathways for them? So one of the partnerships used the predictive tool to identify who might be at risk of going into hospital, and then put anticipatory care plans in place with them. So these are joint plans between patients and their professionals to agree what will happen if something goes wrong or what their care plan will be. And then we help to identify, I suppose, the impact of doing those. So within a partnership area, they'd put 1,000 anticipatory care plans in place, and we were able to track those patients to see what happened to them compared to what happened to the population that didn't have those care plans. So I guess it's useful both at an individual level. So it's putting care straight in to say that patient is in need, but it's also useful at a partnership or at a population level to start thinking about, well, what are the services that are going to be needed in that area. And I guess the term that's on the back of these guys' t-shirts is about data cosmology, and the idea being, I think that it's a small picture and you can get in quite close, but you can also zoom out to be a big picture. And I think that's the strength of individual level data and individual linked data, that you can both provide a service and an intervention for the patient or the client, but you can also start looking at a macro level, I suppose, as what should be needed in the future. So examples across the country actually of using the data is some really go-ahead partnerships like Perth and Kinross have been using our linked data now for a couple of years and are really delving in deeply to ask what more they can do. So with nearly all data, it just raises more questions often, but it allows them to match up, I suppose, what the hard data with the patient experience, the staff experience, and the stories that kind of go around that. So it's not all about making decisions purely on objective data, but having enough to be able to confirm what else you're hearing in the community.
I think that's really interesting, because what I've been finding a bit missing from a lot of the narrative that's going on about integration is the individual patient level. There's been a lot about organisational change and strategic change, and I'm interested in that, but more interested in the individual level. And I think that's the first time anybody's actually explained to me how at that level it's actually already being used to make a difference, and how we could progress to making a bigger difference.
Yes, I mean, it's incredibly powerful when you start looking at an area like Perth City, and you think, okay, that's what's going on in Perth, but actually I can delve right down to a GP practice, and the GP can see, well, that's what's happening to my individual patients. But it's not just within the GP practice, it's also looking at what happens to the patient when they go to hospital, what happens to the patient from social care. I suppose it's the integration really of all the services around that individual patient.
And that helps you then to follow the pathway for the patient, because I think that's been what's missing so much, that everything has been segmented into the GP practice. The GP doesn't know what's happened in the hospital, then the patient gets home, they don't know what's happened, and you don't get that information together. So that's really interesting with that.
And you see one of the partnerships tracked a group of diabetic patients just to look and see what typically happens, or what has happened to individuals. And We have a slide that we sometimes share about a 72-year-old lady who was admitted a number of times to hospital over a number of years, and you start seeing actually where a different intervention could have made a difference to her. That it can be hard to see when you're just looking after the patient in front of you, but when you step back from it and see what actually happens, and the data can paint that picture for you.
Do you have financial data
it's
as
all
well?
costed.
Because that would make a good reason to do a business case for anticipatory care.
Absolutely.
Or transfer of funds into prehab, as we may call it.
Yeah, I mean, we think it's pretty unique actually in Scotland that all of the patient level information that we have for health is costed. So, and it's costed at an individual patient level and then aggregated up. So we can tell you how much any intervention costed or what that pathway might have cost over the year. And then that allows you to build a kind of population picture. We can't do it yet for community health or social care because we only have aggregate data, but by the end of the year we hope to be able to cost at an individual level, not just at a population one. So it's a really powerful way of looking.
Yeah, if we are imagining that the journey is backwards from hospital to the healthy person, which what is the theme of this year, from secondary care point of view, would be also looking at having a business case for the opening up the discharge part of the journey, in which if you have a strong business case to discharge and with, let's say, full package of care and then de-escalate, that would be a no-brainer, and you're also saving money. So that's one of
So yeah, one of the within the reporting tool that we have, you can look at the cost of delayed discharges within your area. So how many people were delayed, what cost it was to the health service, and whether any of that funding could then be reinvested in a different service. Now, it's not to say that that's always possible, because these are sometimes fixed resources in hospitals and so on, but it gives you a very good indication of where you're spending your money and where you might want to spend it differently. And certainly one of the pieces of work that we did that I mentioned around the anticipatory care plans, we were able to cost up the difference between doing that in the community or having patients admitted to hospital. So yes, it becomes a very powerful argument, I suppose, for redesigning how you provide your services. So yeah, a lot of the work that we've done is built on the reshaping care work, and so within the reporting tool we have a series of what we call dashboards, and they're all based on things that the partnerships have told us they want answers to, which have largely come from the reshaping care. So it's costs of things like delayed discharges and high resource individuals, a lot of work on dementia, a really interesting analysis, well, I find it very interesting, of pre and post diagnosis. So we looked at the cost of care in the year before diagnosis for a group of patients and the cost after diagnosis, because there's a myth that costs go up once you've diagnosed dementia, and they don't really, they just switch. So they've switched to being more on prescribing, to more mental health services, and less to acute inpatient activity, which arguably is the better care for the patient involved. But so yeah, and a lot of that has come from what the groups of patients the partnerships want to particularly consider. And one that's very live at the moment is around looking at what happens to people in the last 6 months of life. So where we currently have services and the cost of those services, largely, not completely across the country, but in a lot of partnerships, that's concentrated in hospital. And it's whether, again, any of those end-of-life services could be provided more in the community. And again, it builds a good argument for, on a cost basis, of which you're better doing. But we know from patient feedback that they prefer to be at home in the last 6 months of life. And this starts to bring some I suppose, evidence to it about how we currently provide services and how we might want to do them in the future. So yeah, lots of powerful information in there.
Are there any national themes? I mean, you talked about palliative care and dementia. Are there any others that you can already pick out from the data?
The biggest one coming through at the moment is the high resource individuals.
Right.
So being able to map those 100,000 patients who are getting a lot of care. Probably the next one after that is looking at multimorbidity. So patients who've got multiple diseases, have polypharmacy, who would maybe benefit from medication reviews, and a lot of work going on with pharmacy about how community pharmacists could help intervene and provide services for those. So yeah, a few national ones coming through as well.
I was wondering whether if you would like to have some aggregate data which are not in here, there would be a dialogue that can happen in asking for different datas.
Yes, ISD provides an information request service already, so we collect approximately 200 different data sets across all of Scotland, so as well as health and social care, drug and alcohol services, smoking, workforce information, waiting times, prescribing, quality indicators. Is a massive range of those. So we're trying to put as much that's relevant to health and social care straight into this data set so that people can access it themselves locally, but we also provide information on request to people at an aggregate level, so it's not patient identifiable. But yeah, yes. There's lots more information on this, and I think a demo over at the NSS stand. I work for National Services Scotland, and there's a demo of this particular tool, and also another tool called Discovery, which looks at the quality and safety of hospital care across all the NHS hospitals in Scotland. So do go and have a look. I'll make my plug for that. There's a couple of posters around the place to tell you more, and our website, where again you can, quite a lot of the data we publish on a weekly basis, so you can go and download it yourself at an aggregate level.